basically, then you need to have specialized cannulas. 30 gauge cannulas or 27 gauge cannulas are used to form the anterior chamber, as well as with air, as well as to unscroll the Descemet's membrane. So that's a special cannula which has a tip at the top. If you have a very tight scroll, you can inject into the scroll to open it up. I'm sure the speakers will be talking about all these things. So this is a glass cannula. Glass is always better for Descemet's scrolls because it doesn't damage the endothelium that much. Various vendors provide. The one here shown is the one from DOC. You have from Goider and various companies. Even Indian companies are making them. I think Joja Surgicals has one here in the trade, no financial interest. And this is a homemade injector made by Dr. Siddharthan, one of our instructors. They are available from various people have made different ways. So essentially you need something in which it can go in, and he's using an IOL cartridge here to do the same. I'm sure this video will also be shown later, so I won't spend too much time on it. And I'll just end with this little innovation from Dr. Fogla, in which he's made a nice illuminated artificial anterior stripping block. So you have this backlight, and in this, essentially, because of that backlight, you're able to see the outline of the Descemet's membrane very nicely. I'll just forward to that. I think Kashish is going to show this video. So I'll just quickly run through it. So that's the initial trephination. I think it's commercially available now, I'm not sure though. So you can see the outline very well. So you can see the edge of the Descemet's is quite nicely visible. That's essentially because of the backlight. Okay, so that's as far as the instrumentation goes. I invite the next speaker, Dr. Ashish Nagpal, who will be talking to us about donor preparation for DMEK.
Okay, very good afternoon. Good afternoon, everybody, and thank you, Rishi, for having me here in this course. I think you've been running this course since 2019, and just for the information here, we are the dummies. We are still learning. Every year we come here and we learn something and go back from each other, and it's also very interesting. Rishi keeps rotating the talk, so we keep changing our talks as well. It's not been the same, which makes it more interesting. So this time I got to talk about donor preparation, and I think Rishi has made a lot of my job much easier. I think there is some glitch over here.
While scoring can be done in the chamber.
I'll skip this. I think one important question which arises is where to prepare the DMEK donor, which for most of us in India, I think it's an easy answer that we have to do it ourselves in the operation theatre. Very few of us have the luxury of eye banks who have trained eye bank technicians who can prepare the tissue in advance for you. So that makes it our responsibility. We have to learn how to harvest the tissue. And when we have to learn how to harvest the tissue, the important question is when to prepare it. Because especially in the initial stages, if you're doing it on the same day as the surgery, there's going to be a lot of stress. There are very high chances of tissue loss. They say that almost 5 to 20% tissue loss occurs in the hands of ophthalmic and corneal surgeons. And you will also need a backup tissue. So I suggest, at least in the initial 20-25 cases that you are doing, it would be a good idea after you have finished the wet lab. This is after you have practiced doing it. You should maybe prepare it a day in advance so that you have that peace of mind and less stress. If not, you can prepare it in the morning or before and then plan out the patient. So this is just to get a perspective of when to do it. Instrumentation has been very nicely covered. I'll just keep talking about it as we discuss. The more important part is how to prepare. And in this, fortunately, we do not need a very large corneoscleral rim like in a DSEC tissue. So from the eye bank, even if you have a smaller, thinner scleral rim, that's okay, because we won't be using the artificial anterior chamber. This is just, I wanted to highlight that you should measure, it's not necessary to measure the donor, but it's a good idea to have an idea of the corneal diameter of the recipient, so that it's easy, because in this scenario you will be preparing it much in advance, so it's a good idea to have and plan the sizing in advance. So this was one concept which probably in early 2008-9, when everybody was struggling how to prepare, I think Dr. Art Gibble realized that we need to do a few things. Simple thing was to do this donor dissection inside the fluid medium, and he called it the submerged cornea, using backgrounds away, attractively called as the scuba technique. And I think all of us tend to use a mix of it, because you do need fluid, because the membrane is very subtle, very fluid, very thin, so you cannot just keep it dry, and plus you may further damage the endothelium as well. So this is the most important thing which probably changed how we started dissecting. So a lot of surgeons use a mix of it. You don't actually need to do it in the way which has been described, and it's available on the YouTube. If you look for it, the scuba technique, it's over there. And last night when I was preparing, looking at my videos and preparing, so what to show, to break down the steps of the preparation, and I came across Dr. Fogla's beautiful video on YouTube. I texted him that can I use this video tomorrow, and I took off all my, because this is very beautifully highlighted, all the steps. I've tried to break it down, so we'll just go through it. I think the first part is to place it on a corneal, on any trephination block. In this case they are using the coronet, but you can use any one, whatever you prefer. And the idea is to keep the lower dry. This is first thing you're going to do is do a peripheral punch, which can vary from 9.5 to 10 usually. And as Rishi described it, this is just a partial punch. This is just to kind of mark to kind of have a nice edge which we can lift up. Because the other technique which Rishi had described was the Melis technique, which is the no-touch technique, in which they go from the trabecular meshwork, which sometimes is very difficult to learn and reproduce. So this is a much simpler thing to start off with. And once you have done that, you need to put some trypan blue, because otherwise you can't see anything. So this is purely just for a few seconds, just to stain the edge. This will not stain the desmes as such, unless there is a damage to the endothelium. And once this is done, then you can just drain the fluid out, drain the trypan blue, put some BSS again, and then you start with the Sinski. Sorry, first I think this is a good idea. First is to remove the peripheral DM rim, because that gives you an idea of the behavior of the DM membrane. So once you remove the peripheral rim outside of the donor, then you can start off with lifting the edge. The important thing is to make sure that the edge is equally lifted all around. Sometimes you may go deeper inside if you punch it too hard. If you have a sharp, if you use something very sharp, it may go into the stroma. If you have something too broad, it may not do the job. So that is where you have to strike a balance in finding the right kind of Sinski. And once you have removed the peripheral rim, I'll skip to the next part. In this case, Dr. Fogla is using the one of his DM stripping hook, which he has designed himself, to just lift the edge all around. This is to ensure that the edge is lifted all around like you would also do in a capsular excess, but this is to ensure that you do not have any radial tears, because if it is attached somewhere, then when you are pulling on it, you may cause a tear. I'll show some videos of it later. So once you've done this 360 degrees all around, then you can take a forceps of your choice, like the one which Rishi had showed, which is a broad edge. I'll skip to that part over here. In this case, he's using a curved tying forceps. This is a good compromise, because sometimes in the other forceps you need to hold it perpendicular, which sometimes we are not used to, and it's difficult, it comes in the way. So it's a good idea to use, it's simpler for me at least to use a tying instead of a straight forceps, because it gives you some more edge to hold on to. And then you can just pull on it. This is so beautifully done. It comes out so gently in Dr. Fogla's hands here. And once you have done it, you just peel around 70 or 80% of it, and you leave it there. And then you start with the second trypan blue stain. So you have to stain again the second time now. This time this will be used. This will stain some of the desmes which has been peeled off. So this again is for a short time. You don't need to do it for a long duration. And then you can drain it off, making sure you do not touch. This is an important step. I feel that you can just tilt the trypan so that you just drain the fluid out, because sometimes we tend to maneuver, we keep putting the sponge, trying to drain it, putting some BSS, and that's quite a struggle and maybe causing a lot of damage. So this is a subtle tip which Dr. Fogla has shown, and just to bend it over and drain it all out. And now we are making the stromal punch for the mark, which also Rishi had shown. So you can just use a dermal trypan or a keratoprosthesis trypan. In Dr. Fogla's hands, I think it's working very efficiently. In my hands, I have to hold it, the tissue, make sure it doesn't damage and you have to keep it a little dry so that the desmes doesn't come into the way. So these few things, there is a little struggle at this point, but you need to hold the tissue. Sometimes you can also ask your assistant if you are not able to hold it from the other edge, making sure they do not damage the desmes. And once you have the trypan, you have made a small window. Now what you need to do is float the peeled DM back. So in this, sometimes you just need to put some fluid, and you can put a sponge on the opposite end, which will, with the help of surface tension, kind of flatten the DM. So you can see it's partially strained. The 1/3 of it is not stained because it is still attached. And now once you have done this, you can flip the whole tissue upside down on the same trypan edge, on the same trypan that you are using. And once you have flipped it, you just need to open the window and dry the edge very gently from the sides. Here I would suggest to use not a very dry sponge, use a slightly wet sponge, not a completely dry. And then you can make a mark. In this case, Dr. Fogla is using the Sinski itself to create an F mark. So once that is done, people prefer different. Somebody uses an S. I think Siddharthan uses an L. So everybody can choose their own alphabet, whatever works for them. And once that is done, you can turn it back again with the endothelial side up and do a partial punch again with your required diameter. Either it could be 8, 8.5 usually for most cases. And again, in this case, you don't need to do a full thickness punch, but one can. I mean, if that happens, that is also okay. But then tissue management would be a little more difficult. So if all of the base remains attached, it's usually easier. And especially more so if you are going to use the tissue the next day, it makes it much more simpler. And again, you remove the peripheral donor rim. And then you can just hold it from the edge and leave it there. There is some BSS there, and now you need to stain it the third time, which will be for at least a minute or a minute and a half, because now especially if you are going to use the tissue right away. If you are not, then you can leave it as such. You can stain it just before the starting of the surgery. So this is, and towards the end, once it's stained, it's the tricky part, and I think everybody has their own donor, the glass tubes. There are many kinds available. It will be difficult to discuss all of them. But one thing here is just to pick the tissue up and put it in the Petri dish. And then you can load it from the broader side. And here, this is a very interesting maneuver Dr. Fogla has innovated, in which he takes it in the broader edge and then he moves the fluid to and fro, which helps it to create a double scroll. There is a warning here that it may not work in your hands always. We need to still reach that level of efficiency, but this seems to be the most what I feel is least destructive procedure. It seems to just do it. It's a closed chamber. You're just handling the tissue there instead of struggling in the Petri dish. So this is the ideal way, which I wanted to show, that if everything worked out, this is how probably we would have a donor preparation. The other variation sometimes one can do is that if you don't want to use trypan blue, some people mark the trephine with the marker and then put it so that you can still see the trephine edge. So there is some visibility to it. But sometimes there are some particles which come in the way. You either need to keep it more dry. So that again is not ideal, but that can also be done to improve the visibility. And then again, in this case, as I'm using, what I wanted to highlight was never use the Sinski in a slanting way. Always keep it perpendicular to the cornea so that you get a good cut. Because sometimes we tend to use in a slanting way and that doesn't work. And I think this is, I think Dr. Fogla published this the next year in IGO. It's available, the video and this device. I think this device helps in improving the visibility, and they had done a small study to see how it works in the hands of experienced surgeons versus learners. And you can see it utilizes basically the same retro glow what we do in case of a Rexis. So it may help in improving visualization and also in the stripping, because sometimes there may be some tags, some fibrous parts which you may be able to see at least in your learning phase before you can see the indirect evidence, the signs of it. So I think if it's commercially available, it would be useful. The other way to mark it is to use a F stamp or a S stamp, which is again a fairly simple thing to do instead of using a Sinski. And this is what sometimes you may have a tear right in the center when you're pulling, because each Descemet's membrane, depending on the age, would be different. They would have different fibrous adhesions. So this is sometimes you may have breaks which may ruin the tissue. So you need to be very careful when you're pulling. It is not always as easy as it looked in the ideal one. This is an old video in which earlier sometimes we used to load the tissue from the narrow end. So there will be a lot of struggle before we realized that it's simpler to do it from the other side, which was so logical, but somehow we just didn't think of it at that time. So sometimes this is a thicker membrane. The scroll, it creates a very tight scroll, but still it doesn't go, and it's quite a struggle, and you're obviously damaging the endothelium all the time because it's outside. So it's always not so easy. The other variation is in which the DM will not scroll. It is going to be very adamant, very stubborn. It will keep opening back again and again, whatever the hell you do. So I mean, sometimes what I suggest is on all these, usually we used to do the maneuvers in the deeper part of the Petri dish, because as it comes to the surface, they tend to open up. As it goes lower, you can manipulate the same scuba technique probably. But again, this I think probably will be discussed by some of our faculty on how to manage. And I think I'll end over here. I think time is up. Yeah. Okay.
Yes.
Thank you. I think we'll discuss the rest as we go. Thank you. Thank you.
Thank you, Ashish, for that wonderful talk. I think the videos were lovely and you covered the topic beautifully. We'll go on to the next speaker, Dr. K.S. Siddharthan, again a young dynamic DMEK surgeon who will show us the DMEK dance, ensuring the graft is the right way up.
Thank you, Rishi, for including me in the part of your team to teach DMEK, which we have been doing for the last 2 years. But I think 2020 we did, and after that again we are doing it only now. So the DMEK dance, ensuring the graft way, I think Ashish very beautifully explained the way how the DM is being prepared, and Rishi gave a very brief lookout on all these things. So here I am going to show you completely only videos of how to unfold the DM, how we used to do before and how we are doing now. So this is a very favorite slide of mine. Like the DMEK is pretty difficult because the DM always scrolls on itself, exposing the endothelium out. So this is the biggest problem, because if you take it in a glass or you take it in a fiber, whatever, the DM is out and it's out to get damaged. So here you can see here, you like a DSEC, if you want to put a taco fold, I am putting a taco fold and putting into the saline. The endothelium is actually inside, but the nature of the DM is such that you see it flaps open and the endothelial side comes out. So this is the biggest problem we face, because in DSEC the endothelium is inside safe, whereas in DMEK it's outside. That's why there is so much of loss. So the marking, as Ashish told, you can mark anyway, but I do a L, very simple. This thing is, there's a horizontal short limb and a vertical long limb. So you have to make sure that the short limb is always on the right side, meaning that you are sitting superiorly, nasally, temporally. Make sure, imagine you are sitting on the side of the L, and make sure that the horizontal part is always on the right side. Like you can have an F, you can have an S, that depends on your comfort. But for the beginners, I think this single one should be a very easy one to do.
Your slide's not showing.
Yeah.
Something wrong? Yeah.
It's not open.
Just disconnect and reconnect. That should fix it. Any questions for any of the speakers so far while we wait for him to come back on? Ashish, I have a question for you. Suppose you have started your Desmet stripping in the donor. You've done your initial mark and you're removing the peripheral Desmet and it starts tearing. You said you want to see how it behaves. So now you've seen that it's behaving badly. Will you modify your technique in any way?
Are you back on?
You can still answer.
I think
yeah.
So I think there will be many ways to handle the same thing. The important thing is to identify that it is tearing. So you need to, one simple thing is to turn the tear outwards. Unlike like in the Rexis you want to turn it in this you turn it outwards, so you get as maximum larger as much as possible. So that's the only thing that we try. And of course I would suggest in that scenario you should be using a counter pressure on the Desmet. So just press it with another forceps while you're pulling in that area, and goes very slowly in that area. So this is the thing which I do normally.
I think one more point I'd like to add to your talk, which is very nice, is that when you're stripping the Desmet, you're stripping basically from one edge to the other edge, and as you're stripping it, you have to see the line where it's separating from the stroma. And at any point, if that line is getting kinked, that is the point where it's likely to get a horseshoe tear. So do it very slowly and keep a close watch on the line, and it should always be horizontal. At any point, if you see some folds coming or any resistance, that's where you should stop and maybe go from another side and then continue.
True.
And also if it's torn on one, tending to tear on one side, just start from the other edge and complete. That also helps sometimes.
True. And I think
yeah.
one more thing is, I mean, as I'm reminded of the times, I think initially I remember I would end up changing my Trifine. Sometimes it would be a Teflon block, sometimes it would be. I think it would be nice to have the same one initially so that you get an idea of the counter pressure and tag how much you need to pull, what is the counter pressure. Because I would go to a conference, get a new one, and then start with that forcep, and then end up with a new problem. So I think that's one point which just came to my mind.
That's a good point. Siddharthan, how are you? Shall we start with your talk and come back to you?
Yeah.
Yeah. Vikas. So the next speaker is Dr. Vikas Mittal, a good friend of mine from Ambala, and he's again a very dynamic surgeon, does lots of new things and innovations. He will, I think you run a course on DMEK as well, no? So right. He will teach us how to do wet lab. He has something very interesting which I found very innovative. So I think I'll let him show you.
Thanks so much, Rishi, for making me a part of this this course. And in fact, I had forgotten that I have already consented that. Then when you made a group, WhatsApp group, then I realized that I'll have to make this trip. So so far, whatever DMEK you have heard of or whatever you see, what are your basic thoughts? It's a fab surgery. At least this thought is clear. ये क्या हो गया?
This is also very fab.
This is fab, yeah. हाँ क्या करना? अच्छा, okay. Slide show करना है?
Okay.
ये तो है.
Any other questions while we wait? Yours is ready. Vikas, shall we go back to him, or are you ready?
Got it.
Okay.
So I was there. So it's a fab surgery that we all know. And anything else? What do you feel about the people who do this DMEK surgery? They are fab surgeons. So do you feel? So what next? So do you want to refer them? So fantastic. So one thing is clear. So obviously everybody will appreciate if you send them the DMEK cases. But next 10 minutes or so will be for people like what she said, that I want to acquire this skill set. And this is nothing but a skill set. How many of you are very proficient in FACO and SICS, or either of them? FACO, SICS. You pass the eligibility criteria. So you can definitely acquire this skill set. I didn't say DSEC, right? So DSEC can be a prerequisite to do your DMEK. Why? Because in case you have a problem, you can at least do a DSEC and patient will still feel okay. But to acquire a skill set, you don't need DSEC. It's a different surgery altogether. So all you need to do is have basic ophthalmology training. That's it. So let's see which category you belong to. You want to acquire this skill set. This is sure. You belong to one of these categories. I have never done DMEK. I want to start it. I've started but stopped it because I'm struggling with DMEK, and I'm scared of DMEK. Oh my God, it will get tear, and then I'll see the edematous cornea next day. Then patient is after my life. I'll see, oh no, let's remove it. Oh, DSEC was so good. I have never done a cornea transplant. For this, please ensure that you need a license and ensure that you have a good cornea training. You are an eye bank in charge, and you are thinking of, how about providing a DMEK roles to the surgeons outside. So if you belong to one of these categories, the next presentation is for you only. Why DMEK? I have put up a few photographs just to boast that yes, I can do DMEK. So I'll skip it. We know that this is an ideal transplant, right? Because the many times, I remember one patient who went to a general ophthalmologist after surgery, and he said, doctor has not done anything in your eye. He has taken money from you, but he has not done anything. And he came back running and he started fighting with me. You didn't do anything. He said that there's no, koi putli nahi hai, there's no transplant. So skill set can be acquired, no doubt about that. What I did is, I started doing it in 2013. And this was BOA, Mumbai only. I was sitting with Dr. Fogla. I sat for an hour and tried to understand what it is. At that time, I think 1 or 2 surgeons were doing. They went back, did a few wet lab and tried to do myself and started it. In first year, I did 10 cases, and out of 10, 6 failed. 6 failed, and my confidence was shattered. I thought this is a stupid surgery. DSEK is such a fabulous surgery, and I'm sure that patient will get 6/9, 6/12 easily. Why do I need to shift to DMEK at all? I thought no, DMEK is a bakwas surgery. Then in one of those ESCRS courses, there was this course in DMEK. It was jam packed. I was standing on my toes like that. I stayed there for half an hour. There I saw stamping for the first time. Stamping, I saw, wow. This is what the problem was. I was thinking it is like a flower petal, it will open like this and all those theory that I had. But actually you can see whether it is in the correct orientation or not. And after I came back, I still remember from Delhi, I called my OT assistant and told him that post do 2 DMEKs next day. And after that, there was no look back. And nowadays, when we do DMEK, we know that it will be almost perfect as what I think about DSEK. So just out of this graph, just see, I've highlighted 2 things. Started and restarted. Doing is more important. So you'll have to ensure that you do it. Even if you have stopped, again, redo it, restart it. You will definitely get a hang of it. So DMEK, how do you acquire a DMEK skill set? Just pay attention to the next video. It's a very important video, most important video, and I'm going to show you 3 human beings. Have a look what they are doing, and this will be the crux of all the things. You can't panic. Stay calm. Look at the hair. Look at the hair. Look at the hair. Stay calm. This is the DM will always be underwater. Have another look at this human being. Count how many times he got up again, and got up again, and got up again. So ultimately, there are bound to be learning curves. It's okay, right? And the skill set is different. Rules are different. It's underwater rules. These are not the rules which you apply on DSEK. So don't think that you are a DSEK surgeon and apply with that frame of mind to your DMEK. So what we are going to do in this presentation, we are going to provide you your toolkit where you can develop these reflexes and overcome these learning curves in your own setup. So all you have to do is peel off a DM without tear, then place it in the patient's eye in correct orientation and minimum cell loss. That's it. That's the only thing that you have to do. So there are many simulation model for pilots. Even the flying is not easy, but there are simulation models. There are simulation models for phacoemulsification. So here again, I am going to show you a few simulation models for each step. So what we are going to divide it, we'll split this whole surgery into various steps. For each step, what are the simulation model? How you can set up a wet lab on your own. So there are 2 parts. One, you have to deal the DM outside the anterior chamber, and one, you have to deal with this DM once it has gone inside the anterior chamber. So let's see the first part. How do you separate DM from donor cornea? How do you learn this? So those people who have never done it, you can, who have never touched the DM at all, you don't know how it feels like, you can go in your kitchen, get a hang of, get a onion leaf. And the inner membrane of onion leaf behaves exactly like DM, and you can practice all these steps which Ashish has nicely shown you. All the steps can be practiced here. Initial partial trephination, we do only partial trephination, so that you separate only DM or maybe another 50 or 60 microns of stroma. And then you can ensure that you lift the peripheral ledge, and after the peripheral ledge is lifted, you peel only 70%. This behaves exactly like your routine descent membrane. You can create a punch in this, make a hole, and then place the DM back, flip it, remove this button, and you have this hole, this well in which you can practice your stamping. You can see, you can keep some fluid and then stamp it and see what happens. It smudges. So you'll get a feel of it. You'll get a very good feel of stamp, and you can practice, P, F, L, S, whatever, and see what fits, what suits best for you. And then, once this stamping is practiced, then you have to peel off the complete membrane, the second peeling. And as you can see, this roll looks like a, young roll. When you strip 20 years old, 25 years old tissue, something looks like that. Then you can aspirate it in the injector of your choice. And then you can practice even injection of this DM roll into the silicone eyes. These are the normal eyes that we use for phaco trainings. So you can practice all those steps in the simple simulation model. Once you've got a hang of it, now you know how DM feels like, you can practice on the human donor cornea. Tell your eye bank people to give you some rejected tissues, and again practice all those steps one and one again. Once you have practiced close to 10 human eyes, then you are good enough to go. By that time you'll get tears. Intentionally you can create a tear and then see how it feels like, what we were discussing. If you have a central tear, see what best you'll have to do. So whatever you are going to do in the patient, do it in the wet lab. So next is DM injector. So orientation for the DM injector you can prepare on your own. We prepare it from our rejected patient interface tubes of femtosecond. You can use any silicone tubes. So you just warm it on one side. Then take any injector, so Bausch & Lomb, Technis, whatever, you have to cut it and then just shove this injector into the one part of the tube. Just clean it a bit. So this my OSD assistant makes this injector and makes it very well. And on the other side you can put your syringe. In case you don't want a larger one, you can make a smaller one also. So here again, you can try various things and see what fits best in your hands. And then the orientation, how it is. So once the DM is inside the injector, you can take a magnified glass injector. You can, any in your city, somebody can make it for you. And this plastic roll, you can see when it gets rolled, the endothelium is on the outer side and the stroma is inside. When you inject, the bevel is always up. And when you aspirate it, and when you inject, the bevel is down, and you can see the V side is facing up. And when it opens, the endothelium is down and stromal side is up. So while doing these things, you can develop your macro reflexes. You'll get an orientation, how this DM is going to behave inside the injector. So once you know how to peel off, you've got a hang of what the orientation is once the DM is in the injector. Then comes the most challenging part, when the DM is inside. So whatever problems generally happen, it happens when the DM is inside and you have not got, either you could not get the correct orientation, or you have ultimately did a lot of manipulation and led to some endothelial cell loss. So here again, you can use a simulation model of DMEK aquarium where you can develop your gross reflexes. And then I'll show you how to make a wet lab model so that you can develop your micro reflexes as well. So this is any plastic, balloon kind of thing. This is easily available from any chemical, anyone who deals with the pharmacy. And then you can make a plastic sheet, so roll it and close it. So this will become a DMEK aquarium. This will be like your anterior chamber where you can see how the various things that you are going to do inside the AC, those can be practiced. So there are a few concepts: wave, ripple, pin, flow. All those things you can practice once this is inside. So wave are major waves. You are using 2 cannula, and you are pressing just at the edge of the graft. And by these you are creating a major waves in the AC, and through those waves this graft is shifting on one side. So you can do it with your fingers and see how it is, and it is almost the same that we see in the patient. Ripples are mainly, this is used to center the graft. You make some tap on the limbus so that there are minuscule waves that gets created, and through those waves this whole graft shifts, and you can do whatever centration, whatever way you want to do. Here again, doing this will give you a confidence that what exactly is going on inside. Pin and unfolding, here again you press it one part which is already unfolded, and on the other side you again tap it, make some minuscule ripples and create it through those fluid waves. This will open up. So this again you can practice in this balloon kind of thing before actually doing it. And then the flow, we know that the DM goes with the flow. So in case you have a reverse orientation, you can see this B. So you have to inject the fluid between the iris and the graft. So it gets flipped off. You can see that again you can practice for your macro reflexes, how in case it is upside down, how you are going to make it better. Once you have done, you have got a hang of it, then you can develop your own wet lab model. This again is a very simple thing. You can use this latex material from the gloves. This will make a diaphragm. Over it you place your rejected tissue, then lock it, and your wet lab model is ready. You can practice your pin, wave, all kind of gymnastics. You can make it a chapati roll, triple roll, double roll, whatever, and see how it is. You can make it upside down, then try to lift it. In case you want to decompress it, you can increase the pressure from the outside, so that it will make the AC shallow. So here again you can develop this wet lab model in your own practice and practice it. So once you have done enough practice, you have what I feel is at least 10 to 15 cases of DM separation, and at least 10 to 15 cases of you have done in a wet lab model, then only you take it. And if you have done enough practice, believe me, your first case will look something like that on first post-operative day. You can't even make out whether it's a phaco post-op or DMEK post-op. And this photograph was said, this is a first PODO of one of our trainees who had come to our day DMEK workshop, and recently he had sent me, he did his first DMEK, and you can see the first DMEK also can look something like that. So I don't think you need any 0 year for that. So just read it very carefully. Probability of your starting DMEK is inversely proportional to the number of courses you attend. So if you are attending too many courses, believe me, you are not going to do it. So if you have attended one course, it's okay, it's enough. Please start, do it in your own, and then improvise. You can attend some course to see if there is one point that you are facing a problem at. But if you are attending too many courses, then I doubt. So please go ahead, Dare to Master DMEK. This is the workshop that we did. Thank you so much. I have these videos that we have used in this, and I'll be happy to share these videos with anyone who you like. Thank you so much, everyone.
Lovely videos, Vikas. I'm glad you're part of this course, because I think everybody wants to learn, has to do wet lab, and you've given some really easy ways which everybody can practice with. We'll go back to Siddharthan's talk, and hopefully
it was good that
we'll have no technical glitches.
Vikas might stop talked, and he did, because he had shown all the things which I have showing you now. So it will be really useful if you can see his video again and again, because I'm just going to show it here, and he had made it very simple. So from starting with the DM scroll injection, it's very important that the size of the tunnel is very important, because here, as you see here, I'm trying to inject air, I inject saline, I'm trying to inject the tissue, it is not going in. It's not that I'm using the same amount of section, everything, but you can see I'm injecting saline, thinking that the iris is coming and plugging in or something is happening. But a very simple thing is, when you feel, just slightly extend it from 3.2 to or slightly more size, and try to reduce your positive pressure when you inject. Okay, just reducing the speculum, adjusting the speculum and the size can easily allow you DM to enter in. So first, DM sizing of your tunnel size is very important. The second is your scroll size. So these are very important, because here I am making a mistake, because this is a 6 mm, almost 5.5 to 6 mm opening, and I am using a graft of 7 mm. So you see that it always goes and impinges around the pupil, and it will not open. And in an experienced hand it will open, but when you start it's going to be difficult. Here a case where you are having almost a 6.5 mm pupil, I am using a larger graft. So here, when you have a larger pupil, try to use a larger graft. You can see here that both the edges of the graft are sitting on the iris as a fulcrum, and it opens. So please size your graft according to your pupil size, and that is very, very important for your DM unscrolling. And again, early cases, don't take very young tissues of the 40, 35, 40 and all. Please don't take. And this is a video which I'm showing you, like not to take a young scroll. And actually this is actually an iris claw done, vitrectomized eye, a very soft eye. So all these things don't try in your initial days. After you do your practice, start with around 50-60 years of tissue, clear cases where you have a good pseudophakic, the in the bag IOL and all these things. Otherwise it's going to be really tough to really practice this. So you can, when you take a elderly tissue, you can see that it very beautifully unfolds inside. So you don't need to manipulate, and your confidence levels more. So you see here, as even before putting a suture, I'm giving a few taps and it opens up. So use elderly tissue. Make in mind that you use above 655 to 60-65 when you start, so that you are comfortable to unfold. So here are few of the techniques as Vikas was showing you. I'll be showing here. So initially we used to tap. Initially when we used to we used to tap. But before you do any of this procedure, put a suture. So if it's going to be a 3.2, whatever size, apply a suture before you manipulate the tissue, because the tissue is so small, so thin, it will come out very easily. You can even put a slightly tight suture, because the AC can shallow. So here, before, what we used to do is we used to inject saline, and then we used to tap the tissue like this. So this was what we were doing about 4-5 years back, complete tapping. So this was very destructive, because when you used to tap, just like grapes, how it used to be sticking the DM, the cells will just fall and you'll get a lot of damage. So this was what we were doing initially. And the mark, as I showed you, is which was guiding us. And as Vikas was telling, initially everybody starts. I started in 2013, stopped, again restarted in 2015 after I saw the marking. So once the mark is there, it makes your life very simple. So this was the initial tapping one. And the second phase was when we used to have two hydro needles. You can actually inject little bit saline, and you can do like this. You're seeing how Vikas was showing. It was just the same way. You keep tapping with both hands and you try to unfold. So this was the second type. We didn't want to tap too much. We just wanted to do a little bit of very gentle tapping and unscrolling. But it's not always that this type of unscrolling always happens. And you can see here, I just a little bit speed up for the time. So what happens is, sometimes when you try to unfold like this, and you try to do that, it might not always unfold. So it was not that easy to unfold. So we used to face these type of problems. So what generally nowadays what we do is, we use the hold and release technique. So where with the left hand I hold, and with the opening I inject saline, I shallow. I inject saline, I shallow. See, that's the technique now. It's very, very smooth and it unfolds very, very well. So only thing is, you have to make the tissue lie horizontal always. Don't make it vertical. Always, if you're sitting temporal, always make it horizontal, so that it's very simple, it stands in. So this is, again, I'll just show you a very easy one. So you hold with the left hand, inject saline, hold it, push it to this whichever position you want, hold with the left hand, inject saline, and it opens. So this is a technique which we use. And here I want to show you suppose the orientation is wrong, it goes in the opposite side. This is an old IOL, antechamber IOL. I'm removing it. I done an iris claw, and then after that I am putting a suture, 3 sutures, and then here what I want to show is, like, I'm trying to unfold here, and it unfolds. But you can keep seeing, I don't know whether you can see, it's unfolded the wrong way. It's unfolded the wrong way. I'm doing the same technique, and you can see that the L mark is on the opposite. So here what I do, how do you reverse it? Hold with your left hand. I'm injecting the saline under. You see the tissue, the fluid is going under. With the left hand, I'm making sure that the fold is staying, and with the right hand, I'm injecting saline, and keep looking at the inner flap. You see how the flap came out? So that's how you have to reverse it. I'll show you one more video also. So once it reversed, hold with your left hand and you unfold it. So that's how you have to give the saline under, and that's how it moves in. And I'll show you one more where, again here I'm trying to unfold. So once I unfold, I will find it that it's not in the right side. So you see that I'm injecting saline over the inner flap. You see, I'm keeping on injecting the inner flap, and see how the inner flap comes out, flap out. So that's very, very important. You have to give the flow on the lower inner flap so that it comes out. So again, a few videos, because of no time, I'm just going to forward it. And the only thing which I want to keep telling you is, always make it horizontal, hold it with your left hand, keep injecting saline, shallow it, injecting saline is the key. So that makes it really easy for it to unfold. So these are the few techniques, and one more thing is in regrafts, what I've learned is always try to take a graft size lesser than your graft host junction. Don't go for a bigger one. Here in the initial cases I took bigger one. It's very difficult to unfold. Also in the graft host junction is irregular, so it will not stick properly, and post-operatively you will have problems. And here the initial cases I took a larger graft as usual, how you take in regular cases, but found it really difficult. So this is another case I'll show you. You take it, the graft size, take it lesser than your graft host junction. Maybe if it's 7.5, take 7.25, so that it easily unfolds and the barrier actually does not allow the DM to go out. Yeah, thank you.
Thank you, Siddharthan. Those are really good videos, and I think you gave some nice surgical tips. I'm going to try that inject and release this time. The next speaker is our star speaker, Dr. Rajesh Fogla. All of us have learnt from him, and I think we're all going to enjoy his videos. He's going to tell us how to make difficult DMEKs easy.
Good afternoon, everybody. Yeah, can I have the mics on, please? Yeah. Good afternoon, everybody. Thank you, Rishi, for making me part of your instruction course. I'm pretty sure by now you already know that DMEK is pretty easy to perform. So now let's make it easier in difficult situations as well. What happens when you get a torn donor, like you're trying to prepare your decimate scroll and you realize that you've got a donor so that happens. So it's not something that cannot happen, but you need to know when to stop. If you are facing a difficult situation where when you're trying to peel the DM and you find that it's not going as what you want it to, don't keep persisting with it till you completely damage. The rescue method would be that you try from different quadrants. If it's still not working, you always have the option of converting to a DSEK. That means that tissue can still be, you can do a dissection and punch out and still use that donor for a DSEK, rather than trying to peel and then completely damage the tissue, and then if you don't have a backup tissue, then you have to cancel surgery and patient has to come back another day. So let me show you, this is a situation where I'm peeling the donor. And as I start peeling, I realize that there is some abnormal movement, and you know that visualization sometimes may not be very clear. So we stain with trypan blue, and then I realize there is a large horseshoe tear. So I start my dissection from the opposite quadrant. And so if you have difficulty in one quadrant, you should anticipate the same in the other quadrant as well. So you should go slow. So we were able to peel 60 to 70% successfully, put a F stamp. Then I was trying to do that, and I thought I'll just get a small horseshoe tear without any other problems. But that horseshoe tear extended to the periphery, so it became like a radial tear. So now in this situation, you punched out, but you have a donor that's not completely intact. You do have a large radial tear. If you are inserting into the anterior chamber, sometimes the torn part can get stuck in one orientation, and then you find that you have difficulty to unfold. So whenever I have this kind of a situation, I always try to keep the torn part in the trailing instead of the leading part. The leading part is the normal part of the scroll. The trailing part is the part where you have the torn part. That's because it's usually the leading part that opens up first. So if you can get that part to open up and you have inserted your scroll in the right orientation, you can manage to get your graft to successfully open up. So you can see that there is one large tear and there is also a small tear in the periphery. So if it is very thin, you can always sacrifice it. But otherwise, if you feel that it is fitting into, it's position like a jigsaw puzzle, you can sometimes leave it rather than lose out on that endothelial cells. So you can see here that the graft was in the right orientation when it was inserted, and by peripheral tapping we are able to open up the scroll. The problem in this scenario would be if you had the graft which was upside down, if it was flipped over, then to scroll the graft and make it flip over again, sometimes that stone peripheral tag will prevent that from happening. It will get entangled in the iris and you will find that you are not able to get the graft to flip over. So it's very important that here when you insert, you try to make sure that your graft goes into the right orientation with the open end of the scroll facing up. We can see the F stamp, so that tells us that the graft is in the right orientation, and we place an air bubble. Initially a small air bubble always first, and then you enlarge it. Because if you straight away try to put a large air bubble, that air bubble can displace your graft and you find that it can affect your centration. So how do you put a small air bubble? Take a tuberculin syringe and take only 0.1 cc of air in it, so that even if you accidentally push more, you cannot, because you don't have that extra volume of air in your syringe. If you take a 2 cc syringe and you try to inject, what happens is the air first gets compressed in your syringe because you are using a very narrow bore, like a 27 or 30. So by the time the air comes out from the tip, already the compressed air within the plunger will cause the air bubble to become larger. But if you take a tuberculin syringe and take only 0.1 cc of air, no matter how much you press, you will always get a small air bubble. So that's the same patient. You can see post-operatively, even in a that's day 4, day 5, you can see cornea is looking clear, and at 1 month you can see that the cornea is absolutely fine. So a torn donor does not mean that you have to cancel surgery. So let me show you another situation where I didn't have a backup tissue, and you can see I had that kind of a appearance of the graft. But in that case I didn't want, because the rest of the graft was like an orange peel, it would have been very difficult for me to try and get this to oppose. So I sacrificed that small bit, but I had already stripped a 9 mm area in my patient's eye by then, because I usually prepare my graft in between the surgery. I first go strip the host cornea, do my PI, put an airfill, and then I come and prepare my donor, so that while the donor is being prepared, that airfill will control any bleeding from the PI or anything that happens. So now I have a graft that's only about 30-40% of the surface area, and I have a large. So I said, okay, I don't have a backup tissue, but this was a donor with had almost like a 2,900 cell count. So I thought, let's see. So here we went in. I didn't have any F stamp or any mark on it, so I had to rely on the configuration of the way the tissue was curling. Looking at the edge should always curl towards you. And we managed to, the basic objective was that you try and put the graft in a way that it covers the pupillary area. So we placed the graft, it's curling towards me, then I said, okay, let's go put an air bubble, and always a small bubble first, and then we enlarge it to a larger bubble. That was the end of surgery, and that's how it's in the post-operative period. The overlying dotted line basically tells you the area of the host DM removal and the donor. That's how it was fitting. I was expecting that post-op he'll have a lot of peripheral edema, but surprisingly when he came back a month later, his cornea was looking as clear as this. So either he had a lot of residual peripheral healthy endothelial cells which migrated quickly to cover the graft, because it's unlikely that from the graft you would have health cells growing outward. So most likely the peripheral endothelial cells would have migrated quicker, although he was not put on any Rho kinase inhibitor in the post-operative period. Now to prevent this, this is patented, and now it will soon be under production. Because of COVID it got delayed. This will be an illuminated endothelial punch. Here the advantage is that because of this retroillumination that you get, your donor preparation will become much easier. Any kind of complication that you have, you will be able to pick them up much more earlier, and your speed of preparation of donor tissue will also be much faster. Insertion unfolding, one of the problems that you have with insertion is that sometimes the tissue tries to come out when you're trying to bring the tip of your injector out, so that there can be a partial or total expulsion. And this happens because since it's a fluid-based injection technique, you're flushing the donor into the eye. So if you inject too much of fluid and your AC volume is already filled up, the pressure in the AC builds up, and then whenever you're removing the tip of your cartridge, the injector, as the fluid leaks out, along with that, the tissue also starts coming out. You can do some maneuvers to release some fluid from the side port to lower the intraocular pressure, so that does not happen. But and the other disadvantage of this is that you get an uncontrolled delivery of your donor into the eye. And when you get an uncontrolled delivery, the donor will take one of these configurations. And then you have to follow all these different configurations to try and unfold it. So what if you could, insert your donor always with the, double scroll or the open end of the scroll facing upwards. So a double scroll configuration, yes, by using this agitation of the fluid within the injector, you can get the scroll to open up, and then when it re-scrolls, you can get this double scroll configuration. It works very well between the age group 55 to 65, 70. Younger tissues, you get a tight single scroll. Older tissues sometimes don't have that elasticity to form a double scroll. So even if you try, they will either fold on themselves or they will just form a single scroll. So my basic technique is that I use an AC maintainer, which is on, keeps the chamber formed, so that when I am inserting the tip of my injector into the eye, doesn't engage the iris, so you don't get any iris related complication. Otherwise, what happens is you keep the chamber shallow because you don't want a tight chamber when you're injecting the donor. The tip of your cartridge can sometimes catch the iris, and if you realize, you can create an iridodialysis. Here what happens, because the chamber is formed, you can very boldly go with your injector into the eye. Once your tip of the injector is into the eye, then you can rotate it to the shaft of the injector. You see the scroll, and you see the open end of the scroll, because you're going bevel down. You go inside and then you rotate it in a way that your open end of the scroll is facing up. Then you can ask your nurse to stop the AC maintainer, because you don't want any more flow. And the next thing she does is she disconnects the AC maintainer from the IV tubing. So now what happens, your AC maintainer acts like an egress point of fluid from the from the anterior chamber to outside. So then when you are injecting the tissue, like you see here, when I'm inserting my donor, I gently inject the donor into the eye, then I just wait. The chamber shallows because the fluid is leaking out from the artificial, the AC maintainer. The inferior iris comes up, it catches the scroll. And then when I remove my tip, there is no tendency for the tissue to jump out of the eye. And because the chamber has shallowed, my double scroll configuration that I have put in, it remains in the same configuration. And a double scroll configuration is the easiest to unfold. You just fixate in the center and you tap in the periphery and your scroll opens up. And this, if you see, these are all subsequent videos, and you will find that it's very, very reproducible. These are all unedited videos playing, and an average time of unfolding is less than 3 to 4 minutes. So you can see here, you can just inject the donor into the eye. You just wait, let the fluid leak out from the AC maintainer, and then you disconnect remove the AC maintainer from the side port. That's a 25 gauge AC maintainer. And then all you have to do is to just tap to get the edges to unfold. So there is no flipping over of the graft. You don't have to do too many maneuvers for this. You can see here, you fixate one edge and you tap in the other side and it opens up. These are all the different techniques that you see, what we have shown. If you have I think Siddharthan has already covered some of these, so there is no point in repeating. Shallow anterior chamber is good, it's an advantage, but it can be a disadvantage as well. So if you look at the Japanese population or any of the papers from Southeast Asia, you will find that sometimes the endothelial cell loss rates are a little higher. That's why Donald Tan had to devise an endoglide, because when he started doing his surgery using the conventional technique, he found that the cell loss were more. So that's why he made that endoglide with that platform that prevents the iris from jumping up, because these are crowded eyes with shallow anterior chamber. So here in DMEK, yes, it's an advantage to have a shallow chamber, but sometimes it can be difficult as well. So you see that in pediatric eyes with anterior chamber lens, sometimes eyes with a lot of peripheral anterior synechiae, eyes with short axial length and significant upthrust. So this is basically a case of CHED where we are inserting the donor. Again, the same technique is being used where I am using this is a single scroll, there is not a double scroll. We inject the donor into the eye. Always secure the wound, because when you are manipulating, you don't want the tissue to jump out. And because it's in the right orientation facing up, the unfolding is not very difficult. if you have these kind of small peripheral folds, rather than just keep tapping in the periphery, you can go in, put a small air bubble in the center to lift up the graft. Then what happens is you just put in some saline, the central part of the graft stays up, then the peripheral part is easier to open up because there is more space. Here what happens is the periphery, it's already a shallow chamber, and there it's a fixed fold. So if you tap, it takes a lot of effort to get that fold to open up. So an easier way is to just put a small air bubble in the center and then tap in the periphery to open up. So use air as an instrument when you're trying to do this. In complex scenarios, we also do the endo-in technique, but this requires a little bit of difference in the manipulation that you do. So you have to fold the tissue manually, just like a DSEK graft with the endothelium on the inside. That's a sensor cartridge that I'm using, where using a microforceps, I pull the graft into the tip. Then that's again a ICL plunger that I'm using, which to block the posterior part, and then using a microforceps, the AC maintainer, to keep the chamber formed. You can pull the graft into the eye. Don't let go of the graft so that because it can flip over. So I tap a little bit to get it to open up, then put an air bubble within the scroll, and then you can open up the graft. So this is good, but again, like I said, that each technique has a learning curve. This has a more difficult learning curve because the direction of the flow of the AC maintainer has to be really defined. Otherwise, if it's against your graft, it will make your graft sway, it will make your graft get crumpled. So the decimates is it will just go with the flow of the fluid. So it's not as easy as what we see in some of the videos. One of the companies has come out with a microforceps, which is irrigating microforceps. So it has a sleeve. So there is fluid coming in. So what happens is, so it doesn't obstruct. So when you are pulling in the graft, because the fluid is coming out from this side, it helps in opening up the graft. So there is nothing else to deviate the graft elsewhere in the anterior chamber. So that's the same patient. You can see post-op doing very well. Small eye with significant upthrust, again, using an artificial chamber is good, but sometimes you can put pre-placed sutures, which helps you quickly close the wound. I think in this, it's the same technique being shown to open up. That's the origami fold. Let's look at the... So this is a patient, one-eyed patient, post multiple traps done, previous, lot of peripheral anterior synechiae. So we were contemplating as to what to do. Doing a DSEK is also difficult because he has a shallow anterior chamber. You do a DSEK, you will get the synechiae forming again. DMEKs seem to be the best option. Went in doing the synechial using a cyclodialysis spatula, managed to strip out the DM from the center. But once we did all these steps, then we realized that it was very difficult to get an air bubble into the anterior chamber. So we had to do a pars plana limited anterior vitrectomy because there was so much of upthrust and no way I could fill the ant. So a lot of these angle closure eyes also, even when you are doing this cataract surgery in these kind of smaller compressed anterior segment, doing a limited anterior vitrectomy, definite. So you can see that after we did the anterior vitrectomy, now we are able to form the anterior chamber. You can even see the tube implant that's there. So the tube implant was little longer, so we went ahead using a microforceps and micro scissors. We trimmed out the tube implant. I prepared a graft smaller than usual. It's a 7 millimeter graft. Again, using the endo-in technique because I was sure that once I put in my graft, for some reason, if it doesn't stay in the right orientation, I may have problem in unfolding it. So I loaded it into the sensor injector, then using a microforceps. You can see I'm using the flow towards the graft. I'm not using it at the side because it can... sometimes the graft can get stuck to your forceps, doesn't release from it. So when I was trying to come out with the forceps, the graft was also trying to come out along with the forceps. Again, when we did this, we found that at some point again, the eye became firm. Again, we were not able to form the chamber as what we would want to. Then I had to go in and aspirate a little bit of fluid from the posterior segment. And finally, we were able to get a complete air fill. So that's the same patient. Post-operatively, you can see at 1 month, the eye looks very good. When you do an anterior segment OCT, it's kind of well-formed anterior chamber. So you can do these kind of maneuvers. You always have to size your graft. If you go with the same standard sizing, this is a post-failed therapeutic graft where we are trying to do a graft. DMEK, but you can see that the graft looks bigger than what the volume is. Part of the graft is actually trying to stick out of the wound because there's not enough space. So it's important that you measure your corneal diameter, because here I was trying to look at the normal diameter of the cornea, but you don't have to look at the normal diameter, you have to look at the diameter of the graft, and then you have to prepare your graft that's slightly smaller than that. I think you would have already covered about air bubble, using it in very, very soft eyes, vitrectomized eyes, where you cannot shallow the chamber, and you can see that the cornea has become concave and still I'm not able to get that scroll to open up. So then you can put a small air bubble within the scroll, and then you can use that air bubble as your instrument to try and get the graft to open up. So I find this quite useful. Again, to put a small air bubble, use the same thing, use a tuberculin syringe with 0.1 cc of air, and just use that to put a small air bubble within the scroll and open it up. These complex eyes also, you need to be watch out for fibrin, because a lot of times when you do synecholysis and you're doing your surgery, because of bleeding and because of fibrin formation, you can get your graft getting stuck in the angle, and also your graft fold getting stuck to each other, and no matter how much you try to open, it's very difficult. So when you're doing a lot of synecholysis, always do a complete air fill, wait for 5 minutes, and then go and wash out the anterior chamber, then only you insert your graft. I think we are almost done. This was again the last case. This was a patient post-trab. So in a vitrectomized eye, so again the same issue. Yeah, it's okay. So one other thing that you can do when you have a patient with a large filtering bleb is that post-operatively, the air can go away very fast. Even if you use gas, the gas does not stay in the eye. And sometimes the eye pressure can be low because the patient had a trab, over-filtering bleb, a corneal edema. So what you can do is you can do mattress suture and put the mattress suture over the bleb. That prevents the air from leaking out from the anterior chamber. So you get post-operative, the chances of detachment are much less. I think I'll stop at that. I think our session for the time is over.
Thank you, Dr. Fogla. We can't get enough of your videos. Fabulous.